Are you dealing with a pain in the front part of your hip or your groin, and you notice it more with turning, twisting, squatting, or simply lifting your leg or bringing your knee to your chest? You may be dealing with FAI, femoroacetabular impingement. FAI is a condition that deals with bony growth along one of or both of the bones that make up the hip joint itself. These two bones, when they become irregular or overgrown in shape, cause a little bit more friction as you go through your day-to-day activities and normal everyday movements. This additional friction or contact between those two surfaces can accelerate the wear and tear on not only the bone, but the cartilage around that bone, and can lead to pain with simple movements or just restrict your mobility and ability to move comfortably throughout the day, causing limping or other compensatory strategies. To better understand FAI, we need to know the anatomy and all of the pieces and parts of the hip. So let's take a little deeper look into that. As you see on the graphic, we have a few different bones that make up the hip joint. We have our femur, which is our thigh bone, and then we have our pelvis. That makes up the socket part of this ball and socket joint. The acetabulum is the socket portion that the femoral head, the ball, goes into. This is a very deep joint, which means that it's also very stable. And that's part of the reason why it's rare to hear somebody suffer a dislocation of the hip, except for in high trauma or forceful activities, such as something as a car accident. Now, this ball and socket joint allows for mobility in a variety of different directions. The hip can flex and extend, it can ab and adduct, which is an in and out motion, and it can internally and externally rotate, which is the rotation going in and the rotation going out. And it can also do any combinations of those motions together, one that you'll often hear called circumduction, which is what it sounds like, a circular motion of the hip. The labrum is a ring of cartilage that goes around the lip of the acetabulum, and this helps provide a little bit more stability for the joint. In addition to the bones and the cartilage, you'll also have a variety of ligaments, as you can see depicted on the graphic here. Ligaments connect bone to bone. So what they do is they provide a little bit more stability. They almost act like the emergency brakes for the body. Muscles help produce motion and slow down motion. Ligaments are there for when we do something in an extreme position, or we do something unexpected, or moving a little bit more forcefully or quickly than we anticipate. You can put yourself in positions where you may end up stressing those ligaments. Now, there are also a variety of muscles that are around the hip complex. And the hip is a very busy area, so we'll highlight some of the bigger muscles, but appreciate there are some smaller muscles that play a larger role with either stabilizing the hip or helping with some of the finer articulations that the hip does. The two different types of FAI that you'll hear referenced are cam and pincer lesions. And sometimes you can actually have a combination where you have both types of lesions present. A pincer lesion has to do with excessive growth of the socket. So for these people, often the socket is overgrown and it extends further than what you would normally expect it to. So it actually covers more of the femoral head than a traditional socket joint. The other portion, the cam lesion, that has to do with the femoral head or the femoral neck being too large for the socket. So you can almost envision that head being too large, and it makes it difficult for rotation and other motions to happen within the joint. And then you can also have both present, where you have an overgrowth of the femoral head and neck, the cam lesion, and an overgrowth of the acetabulum, the pincer lesion, which both interfere with how the joint articulates. More often than not, when people are experiencing these symptoms from FAI, they're going to present with a degree of pain. They're going to have decreased range of motion because, remember, the bones are too large, so they don't move very well. And they're going to have some degree of loss of strength or function, and that can be either pain dependent or movement related because they lack mobility. So how do you figure out if you actually have FAI? Well, if you've been experiencing difficulty with any of the activities we just mentioned or exhibiting the symptom profile like we just displayed, it may be in your best interest to go see a physician or a physical therapist to see if they can help diagnose what is going on. When you see that healthcare provider, they will typically do some clinical testing, where they will look at your range of motion and also perform a special test looking for any signs and symptoms of impingement. Now, if you have these positive signs with impingement, it doesn't mean that you have FAI, but it means that you may be more likely to have FAI. The gold standard, though, for diagnostics is going to come down to medical imaging. And typically the first thing that they will order is an X-ray. X-rays are very good at outlining the bony landscape of what we have going on, and you should be able to clearly visualize what the hip socket looks like, and if you have characteristics consistent with that cam or pincer or combination lesion that we mentioned earlier. In addition to X-ray, they may opt for further imaging, such as an MRI, or another type of imaging that allows them to see the soft tissue around the area as well, and see if there's not only any bony involvement, but any involvement of the muscles, tendons, or cartilage in the area as well, to help determine the best plan of care and what your overall expectations should be. So let's take a look at some of the common basic tests that you'll go through as part of a clinical exam. And keep in mind, your individual exam may include more or less than this based off your own specific situation and what information needs to be gathered. But if we're looking at a test to look at impingement of the hip, a common one that you will see done is bringing the leg up, bringing the knee towards the chest, then we're going to bring the leg over, like we're trying to bring it across the body, almost over top of the belly button, and then we're going to rotate the leg out, meaning bringing his foot out, which is going to be internal rotation. When doing that motion of bringing the leg up, across, and rotating the foot out, we look for the presence of any pain, any apprehension, and when we look side to side, if there are any big differences between the injured hip and the uninvolved side. Some common range of motion testing that'll be done, be looking at how the hip moves in isolation through flexion, extension, ab and adduction, and internal and external rotation. So to look at hip flexion, there are two different ways that we can look at it. We can look at it with a bent or a straight knee. When we bend the knee, we bring the knee up towards the chest, and the way the hip socket's oriented, it is not a perfectly in-line up and down motion. We actually bring it out to the side just a little bit to stay in the plane of the hip socket. And with this, we go up as far as we can till we feel a little bit of resistance. Now, the other way that you can look at hip flexion is also with a straight leg. Now, when we do this, we're going to get the hamstrings on a little bit more of a stretch. So the motion may not be limited exclusively by what the hip joint can do, but what the hamstring muscles and soft tissue on the backside of the leg can do as well. Now, to look at rotation of the hip, we bend the knee and the hip to 90 degrees, and then we can rotate the hip into external rotation, and then we can go the other direction into internal rotation. With this, you are typically going to have more external than internal rotation. And you can look at the other side for a comparison, but there are also some normative ranges that you should be able to do to look at how you stack up against the general population, but also your other leg. To look at abduction of the hip, we can keep the leg straight, we can bring it out to the side, and see if we get any stretching, pinching, pulling on the inside part of the thigh of that adductor muscle group that we talked about earlier. And then I'll have you lie on your stomach. You can also look at rotation from this position on their stomach. And the difference between this and when we had them on their back with the hip in that 90-90 position was that now we have a straight as opposed to a bent hip. So we're still looking at rotation. This is internal rotation where the foot goes out. This is external rotation where the foot goes in and across. But we are doing it from a neutral hip position as opposed to a bent hip position. You can also look at extension from here, again with a straight or a bent leg. And from here, we can see how well the leg comes up off of the table, seeing if they get any pulling, pinching, or sensation in the front part of the thigh. We can also do that from a bent knee position, which is going to put a little bit more stretch on the quadricep muscles on the front part of the thigh. And then we can see how well we're able to extend the hip from this position as well. Variety of other motions that you can look at if you want to get a little bit more specific with different positioning of the hip, but those are some basic ones that you'll see as part of your clinical exam. When we look at strength testing for the hip, again, this is a way that we can isolate different muscle groups or different tissues to see what's provocative and if it has any influence or relationship to the potential FAI diagnosis that you're dealing with. Now, with FAI commonly causing pain in the front part of the hip, the main muscle group that runs through there is our hip flexors. So it's important to look at this so that we can see how functional they are, and also if some of the pain that we're having may deal more with the tendon or the muscle of the hip flexors as opposed to the hip joint itself. A simple test that you can do for this is a straight leg raise test. And in this, the most basic form is to have the individual start with their toes pointed up so that they're not rotating out to the side. We're going to straighten the knee as much as we can by flexing the muscle in the thigh. And then we'll ask the patient to lift their leg to the height of their other knee, and I'll just hold my hand there so they know how high that is. Good, and then lower back down under control. Now with this test, and you can relax, what you're looking for is their ability to lift the leg off the table. And for some people who are highly symptomatic, that may be very challenging or painful for them to do. If they're able to do that though, you can add a little bit of resistance. So this time we'll bring the leg up. We're going to ask them to hold right there, and we're going to give them a little bit of resistance and see how well they're able to perform and tolerate this position. To tease out different hip flexor muscle groups, you can rotate the foot slightly out or rotate the foot slightly in. And that will determine on if we're putting more stress on our TFL, our rectus femoris, or our psoas muscle groups. Another hip flexion strength test that we can do is from a seated position. So for this, we'll have them sit up. We'll bring them to the edge of the table, similar as if they were getting ready to do a leg extension machine at the gym. And I'll have them have their hands on the table so they don't have to worry about balance. And with this leg, I'll have you raise it up to my hand. Hold right there. Don't let me push you down, and relax. With this test, we now have them in a bent hip position. So we're putting that muscle group, we're putting the joint in a slightly different starting position. This may see a change in their performance or tolerance and clue you in as to what you're dealing with, either from a joint involvement or from a muscular involvement. Now from this position, we can also test rotation of the hip. So rotation of the hip from this position is going to look like this. Foot in is going to be external rotation. When testing external rotation from a strength standpoint, it's best to have one hand down by the inner part of the ankle, the other hand stabilizing up by the outer portion of the thigh. If I were to apply pressure and move him, I would be moving him into this direction. So he is trying to pull his foot across. And what I'm going to tell the patient is just to meet my resistance. So as I start to give him some pressure, he is trying to stand his ground and not let me move him. Good. Then we can do the exact same thing for the other direction. I'll have one hand on the inside to stabilize, have the other hand on the outside. It's important not to push in or out because we don't want it to be a knee motion. We want to push across. Same thing, I'll push in, have him meet my resistance. So now let's take a look at strength testing for the inner and outer portion of the thigh. So if we're going to look at the outside portion of the hip, at hip abduction, we'll have the patient in a side-lying position. So we'll have the patient lie down, we'll lie on our left side so we're facing away from me. We're going to have both legs straight. The top leg we are going to bring up off of the bottom leg, and to make sure alignment is ideal, we don't want the leg to drift forward, and we don't want the leg to rotate out or in. So typically, we'll just have them coached up to have the toes pointed straight ahead. From here, I like to keep one hand just on the top part of the hip, so that way I can monitor if they are coming back or forth, and then the other hand will be down at the lower end of the leg, just above the ankle. From here, I'm going to apply some pressure, and they are going to meet my resistance and not let me push them down. This is going to work largely the glute medius and glute minimus, which play a heavy influence in the ability to abduct the hip. Now, if we're looking at hip adduction, adduction, this is going to be more of the inner thigh muscles. And there's a couple different ways that we can do that. One can be done from this position, where you have the individual place their leg onto your shoulder, and you can have them put their right hand onto the table to help them balance and support. And then from this position, first thing they're going to do is just attempt to push into your shoulder and just generate some tension in that muscle. So I'll have you push down into my shoulder and see if there's any discomfort or any pain with that. Now, if they're able to do that, fine, and you have a pretty high functioning individual, you can actually ask them to push hard enough into your shoulder to try to elevate their hips off of the table, and they can use their hands to help with support. So we'll push down, come up, and then lower back down. Good. Now that is a pretty high level test for those muscles of the inner thigh. A more basic version that you may see is having the individual lie on their back, have both knees bent so the feet are flat, place your hand and your elbow inside of their knees, and then have them simply press into your arm and your hand, gradually build up pressure, and see if there's any discomfort or apprehension with this. This being a more entry-level, introductory portion of the test, one thing that's challenging with this, though, is you have both legs testing at the same time. So that may influence them positively or negatively in regards to how much they can push, how well they're able to compensate and maybe hide some of their limitations. So doing the side lying variation allows you to isolate that leg of choice. Just keep in mind it's a relatively high level test, so you have to be selective with the population that it's most appropriate for. To test extension of the hip, there's a few different ways that we can do this. A quick, simple way to test from this position is just having the individual do a bridge. So we can have them keep feet on the ground, bridge the hips up, see if there's any discomfort, any pain with that. Keep in mind that we don't want to have the knees shoot out to the side, so give them a landmark of how narrow you want them to have it. If that is easy, you can try doing a single leg bridge. So we can use hands on the table to help with balance, and we can try to elevate our body off of the table. Again, looking for the presence of pain or just the ability of one leg versus the other, and if there's any asymmetry there. Another way to isolate it would be to have them lie on their stomach. We can elevate the leg of choice off of the table, and you'll have an idea of what they're capable of doing with this motion from your previous range of motion testing. Then from here, I'm going to let go of the leg so don't let it fall. I like to keep a hand on the back, just to have an idea of what they're doing there. And then just above the ankle, pressing down and asking them to hold their ground. Don't let me bring your leg all the way down. With that, those are some basic table testing measures that you can do to get an idea of their tolerance and competence with various isolated muscle tests from strength and stability of the hip joint. Now, in addition to the table testing, there's some other functional tests that you can do to get an idea of their overall abilities and movement profile, in addition to what's provocative and not provocative. Now, with these are not formal standard assessments. These are just quick and simple things that your healthcare provider may do to get a general idea of how you're doing, because these often correlate with the presence of FAI. So, first thing that we'll have them do is stand tall, and they're going to bring their knee to their chest. And with this, they will pull the knee up as far as they can, lower it back down, do the same thing on the other side. I usually have them do 2 or 3 on each leg There's a little bit of a balance component to it, so you get a quick idea of what their single leg dynamic balance is, but they also tend to get a little bit loosened up and a little bit more familiar with the motion with each rep. So a few on each leg. That knee to chest motion is typically irritable and limited for somebody with FAI. Now, a second thing that you may see them do are different squatting variations. Common theme of the knee getting closer to the chest is something that people with FAI struggle with, and squats tend to be an athletic and a functional movement that most people will report pain or difficulty with. So with this, as you're watching, are they able to get adequate depth? Are they shifting one way or the other to avoid loading that painful or limited side? And overall, what is their tolerance to it? Another thing, if you really want to emphasize that deep squatting position, is have them get into almost more of like a catcher's stance. So all the way down into the lower position, they can bring their heels off the ground if they need to, and just seeing how well they tolerate that deep squat position for any extended period of time. And then a third quick and simple test that you can do is a single leg squat variation, giving you an idea of how well do they have stability, strength, and mobility in a single leg stance. Allows you to get a quick and easy measure to the other leg. Also helps with appropriate exercise selection in the future as well. So for this, we'll have them step onto the box. We'll have them place one foot on the box, the other foot on the back side of the box. I always tell them, point the toes down and keep contact with that box. As he squats down, he's going to lower the foot down, tap the ground, and come back up. Things to keep in mind, what is the height of the box that we're using? So this is a 12-inch box, but you could just as easily make it higher or lower to accommodate their height and their physical abilities. Have them typically do somewhere between 3 to 5 reps on one side, 3 or 5 reps on the other side. And those are 3 simple functional tests that you may see performed in your PT evaluation. Based on your symptom presentation and what is found with our table testing and functional test, that will ultimately dictate what types of exercises you're going to be prescribed. However, 3 stretches that I commonly find myself giving people with FAI tend to be these 3 that we're about to show. And the first one being a hip flexor stretch. With this one, we can have the front foot propped up on something such as this 18-inch block that we're on. Stairwells also work really well. Now we have the front foot propped up, the back foot on the ground is flat, and the toes are oriented as straightforward as possible. They may be angled out a little bit, but we're trying to get them as forward-facing as possible. With this, balance should not be a limiting factor. So they can have their hands on their legs or they can have their hands on the sides. If they're in a stairwell, railings on the sides work really, really well. And with this, we are not forcing a stretch. We are just trying to get some gentle movement in, taking what the hip gives us. And I tend to really like this one for people who spend a lot of time sitting. When they get up, they go to move around, they're a little bit stiff in the front of the hips. This can help open things up and loosen them up to get on with their movement. Now, from this position, we can also reorient so the front foot stays the same, but this bottom foot is going to face down this direction now. And now this is going to be more of a sideways drift back and forth. This is going to target more of the inner thigh and the adductor muscle. So it may feel like more of a groin than a hip flexor stretch. Same rules with the other one. We're not forcing the motion. We're going as far as we can. And keep in mind that this top leg is going in to some greater degrees of bending. If that is a motion that was found to be sore on the table, then we would modify the step height and the distance that they are going to accommodate whatever they can tolerate. With these, 5 to 10 reps on each side with each exercise tends to be a really good and efficient number to utilize. Now, the next one that we're going to do, we're going to make our way over to a table for. So the previous stretches were more for the front and the inner part of the hip. This one is going to be felt more towards the back and the side of the hip. Now for this, a table, a couch, a bed, all works really well. And we're going to have one leg up onto the table. as the other foot stays on the ground. Now, with this, we're going to keep our body oriented forward, and you may feel a stretch in the side and the back pocket just getting into this position. If not, you have the option to put your hands in front, and the further you reach out, the larger the stretch will be. Some people are able to get their chest all the way down to the table. You should be able to breathe comfortably during this stretch. As you are holding the stretch, hold it for about 30 seconds. You can take 5, 6 deep breaths in and out. A good rule of thumb though, if you cannot carry on a conversation or you cannot comfortably breathe in and out, you're probably pushing a little bit too far. Now, another thing that you can do from this stretch in this position, he is able to do a good job of keeping this knee on the table. For some people that may be challenging and you may see the knee propped up. If that happens, take a pillow, take a towel, take some sort of object and wedge it under the leg, and then that way it'll support them. A good rule for progression is to try to remove some of that support every week and see if we can gradually work that knee down to the table and then eventually leaning forward. So this stretch, great for targeting that back side of the hip, some of the rotators of the hip that we talked about earlier, and the glute muscles. And the last stretch that I really like for FAI is doing a kneeling quad stretch. And this is going to target the quadricep muscles, and it's also going to get a little bit of that hip flexor as well, depending on how much you exaggerate the stretch. So for this stretch, we can use any object to put their back foot on. Couches, chairs, dumbbell benches in gyms work really well. Here we're using a 12-inch plyo box. For this, don't worry about the space that's in between your heel and your back pocket. With this, we care more about having a nice straight line from our shoulder through the hip down to the knee. To get a larger stretch, we can do a few different things. We can bring this front foot out a little bit further. We can bring our body forward, and I think about not bringing your chin forward, but bringing your belly button forward so the whole body drifts forward. Or we could prop the back foot up onto something a little bit higher. Same guidelines as the last one though, about a 30-second stretch. Take nice deep breaths in and out. You should be able to comfortably breathe in and out and carry on a conversation. 2 on each side works great. With regards to strength training, there's going to be a variety of different approaches and a variety of different exercises that are all great options to do. So for the purpose of this video, we're going to focus on strengthening the hip flexors and what may serve as an example of one progression or sequence of exercises that you'll see utilized. We're going to start off with an isometric version, then we're going to go to a resisted version, and then we're going to integrate it into a total body movement pattern. So the first thing that we're going to do is going to be a half kneeling isometric hip flexion activity. So for this, we're going to come up to the wall and we're going to have one knee on the ground with the left foot in front. Perfect. Now, I don't want balance to be a limiting factor, so they can utilize the wall, they can utilize PVC pipes, anything that they need to help with this. And the first thing that we're going to try to do is we're going to try to lift and elevate that front foot just an inch off the ground and hold for 3 seconds. After 3 seconds, we lower back down. And we'll repeat this 5 times. With this, we are working on isolating the hip flexors. We're keeping our body and our trunk nice and tall. If we need to, we can think about incorporating the core and making sure that we are not crouching or bending forward as we do this. Now, as we get better at that and it becomes easier, meaning it's not painful, we can lift the foot higher, we can lift it for longer amounts of time or for more repetitions, we can start to add a little bit of resistance through a larger range of motion. So for this next one, we'll stand up and we're going to have this band going around the balls of each of our feet. And we'll walk up to the wall so that way we have something to help with balance. And then from here, we're going to take our left foot, keep it on the ground, and we're going to lift the right leg straight up in the air and then lower it back down under control. We're gonna do a set of 5 of these. After we do 5, we'll switch to the other leg. How many you're doing, your PT can help you out with what's a good rep range for that. We typically work up to the 8 to 12 range with this type of activity. With this, we want to make sure that we're not excessively shifting side to side as we're lifting the leg. We want to think about being tall. So we're keeping the top part of our head up towards the ceiling. We're not leaning forward as we're doing this. Now, after we've worked through this, we can take the band off, and the last thing that we'll do is going to be integrating this into a total movement pattern. So we're going to have both hands at the wall, and we're going to have our left foot forward and our right leg back. Then from here, we're going to drive off of our front foot and bring the back leg forward. Control on the way back and up on the way forward. So let's try a set of 5 of those. Good. With this, we got the front foot flat, the knee is loaded, it is not pulled back. We have a nice straight line from our shoulder all the way down through our back foot. This back foot, we're on the toes. We don't need the heel down for it. And then from here, we'll drive up. Good. And then back down under control. With this, you can incorporate a little bit of tempo to it. In the beginning, you'll probably go at a more slow, controlled, deliberate pace, but you can add in a little bit of speed, a little bit of tempo. You can hold at the top. You can make it as easy or challenging as you need to based off where you're at in your rehab process. These 3 activities, the half kneeling isometric, the standing resisted hip flexion motion, and now this total body integration, this is a simple but effective sequence of hip flexor strengthening that you can do that you may see as part of your FAI program. So we have covered overall what FAI is, the anatomy that's involved, some of the diagnostics and options for care, and we did a brief overview of what a session at PT may look like with regards to clinical testing, mobility, and strength exercises. There is a lot of different things that you can do from a conservative standpoint for FAI. And after meeting with your healthcare professionals, whether it's an orthopedic for diagnostics, or a PT or a rehab professional to help develop a plan of care, you'll have a more in-depth and customized template to follow for your own specific situation.